This demonstration is one of the method of evaluating the comatose patient. The patient whom we have for evaluation at this time is a 63-year-old lady who was admitted to this hospital 5 days ago in the state of coma in which you presently see her. We have the history that she had suffered from hypertension for some years and had been treated for that condition. A week prior to the onset of this coma, she developed rather suddenly some double vision and vertigo. This lasted for several days and then declined somewhat. On the evening before her attack, she seemed reasonably well, went home, and was known to have prepared for bed. She was, however, found the next morning sprawled on her bed, completely comatose. The examination which was done at that time is practically identical with that which we will demonstrate at the present time. This patient, having been in the hospital for several days, has already had an evaluation of her blood pressure, of heart and lung function, of metabolic and electrolyte status, so that we know that these functions are all perfectly normal. Hence, I will go directly to the evaluation of the neurological status of the comatose patient. First of all, let us consider the state of disturbed consciousness. You see, this lady appears as if asleep, eyes closed, with regular respirations. Obviously, then, we are not dealing with a state of delirium with disturbed awareness. Also, we are not dealing with the condition called akinetic mutism, because her eyes are closed and she is deeply comatose and unresponsive. If I attempt to arouse her, we get no response, such as, "Mrs. Campbell, Mrs. Campbell, look here, please, look here. Mrs. Campbell." If I put in even a painful stimulus, we get little response except for the reflex posturing of the limbs, which I'll return to later as far as its significance. So we'll have to say that this is a state of ordinary coma. Now we want to go to the evaluation of the cranial nerves. First thing to be done is cranial nerve 2. And on fundoscopic examination, we see that the disc is normal in appearance and there's no papilledema nor any hemorrhages. Same is true on the other side. Now we would like to go to the pupillary reflexes, which tell us something both about the second cranial nerve and the third. On this left side, we see that the pupil is about 3 millimeters and does not react at all to light. On the right side, you may not be able to see so well, but I will tell you that this pupil is slightly smaller, but reacts quite briskly to light. Now, with this situation, we would say that the second nerve and the pupilloconstrictor fibers of the third are perfectly intact on the right side. On the left side, something could be wrong with either. However, if we shine the light into this eye, we see that this one constricts. Consequently, the second nerve is intact. The fibers have gone back to the midbrain, to the Edinger-Westphal nucleus, have innervated it, and have caused the pupillary constriction. That reaction is blocked on the left side, therefore we have an abnormality of the efferent arm of the reflex, hence a part of the third nerve. Now there are other features we may observe about the eyes. Note that the pupils are a bit unequal. This one is smaller than the left one. Also note that there is a difference in sweating on the two sides of the face. I believe you can see beads of perspiration over the left forehead and face. none whatsoever on the right side. Therefore, we have an abnormality of the sympathetic fibers of the brain stem supplying this side of the face. There is a Horner's syndrome. Some other features we can see on examining the ocular movements. Observe spontaneously that every now and then there are little vertical movements of the eyes. They beat downward and then come back up again, dip downward and come back up again. This phenomenon is called ocular bobbing. This is one of the few pathognomonic signs in medicine because it means invariably that there is a large lesion in the region of the pons. Now, having made those observations, we now want to see something else about eye movements, and that is what degree of reflex motion can be obtained. And Dr. Parker? We will now do the oculocephalic reflex, in which I will move the head passively. First to the right, quickly, now to the left. And I think you can observe that this movement to either side produces absolutely no deviation of the eyes. Now, in the comatose patient who does not have any paralysis of the gaze centers, if I turn the head to the right, then the eyes should move in the opposite direction. Here they do not. This tells us then that the conjugate gaze centers and their reflexes in the pons have been impaired. Now we shall go to the fifth nerve. One test would be the corneal reflex. As I touch the cornea, there is a weak but definite constriction of the eyelid. Therefore, the corneal reflexes are present. This tells us that the fifth to seventh nerve arc of that reflex is present. At times, if we put in a painful stimulus to the face, we see grimacing. That also tells us that the fifth nerve is intact and functioning. Now just observe the face. And here is a yawn spontaneously. This tells us that the seventh nerve nuclei are intact. You notice the symmetry of contraction of the face during that yawn. We also see that at rest, the face is about symmetrical in tonus. To examine the eighth nerve in the comatose patient, one must use the caloric responses, which will now be done. In this, the head is in the 30-degree angle with the horizontal, and cold water is irrigated into the ear. We look for movements of the eyes in response to that caloric irrigation. Now we may see some motor responses also. Yes. Now as that is irrigated, we see that the limbs go into a state of extensor spasm, but the eyes are not moving whatsoever. In the patient with simple coma without brainstem impairment, the eyes should move to the side irrigated. They do not do so. There is no movement. We will not repeat it on this side, but I can tell you that irrigation of the right ear also fails to produce any response of the eyes. Consequently, we have additional evidence that the caloric reflex, which goes from the vestibular nerves to the conjugate gaze center, is knocked out. The eighth nerve itself is intact, though, because its stimulation produces the spasms in the limbs, which is a form of decerebrate rigidity. Now finally, in the cranial nerves, we have to evaluate the 9th and 10th. And Parker, I believe if you could hold the jaw down, let me see, hold the jaw down. And I will see if we can demonstrate. I can only state here that the palate is in the midline and that the gag reflexes are present. The cranial nerves then, in their examination, have disclosed some very definite abnormalities. Now I would like to go to the whole body view where we can evaluate the motor system. Note that the patient has no spontaneous or voluntary type movements. Stimuli to the palms produce nothing, and the hand falls limply if dropped. Similarly, on the left side, the limb falls. Stimuli to the limbs does not produce any attempt to withdraw or fend off the stimulus. However, we have already seen that there were some abnormal postures of the decerebrate rigidity type. And if you will observe the arms and legs again, I will put in a stimulus through the trigeminal nerve, and there you see the typical pronation and extension of the upper extremities, the extension of the lower, which is the typical position of decerebrate rigidity in man. Now we can check reflexes very easily, just as in the awake patient, and observe that these stretch reflexes are present at about the 1+ level, and they are quite symmetrical. In the lower extremities, we get brisk knee jerks, which are about symmetrical. We get ankle jerks, no clonus, and during the plantar response, we get a clear abnormal response with extension of the great toe on both sides. Sensory examination can only be done from the point of view of responses to pain. We have already seen that these are minimal, but if we put in some painful responses, we can get reflex withdrawal. This is not voluntary, this is reflex. This at least tells us that the pain pathways are intact as far as the spinal cord and brain stem. We have now seen that in this comatose patient who is unable to cooperate, that it is possible to assess all of the major functions of the nervous system and to make an anatomical diagnosis. The state of coma could have resulted from dysfunction of the entire nervous system or some abnormality down in the reticular formation of the brainstem. Our examination confirmed that there was brainstem damage. Now, if we will look at this diagram, we might review some of those data. Remember that the left pupil failed to react because of paralysis of the efferent arc. Therefore, there's something wrong in the pupiloconstrictor fibers coming out of the Edinger-Westphal nucleus on this left side. And I will just draw in some shading there. Coma from reticular formation damage can occur by involvement of the reticular formation in the midbrain here, such as through here, or down in this next diagram in these parts of the reticular formation. And I'll dub that in. Remember that there was a Horner's syndrome on the right side. That implicates sympathetic fibers which are traveling through the pontine tegmentum in here. So we will extend our lesion to there. The decerebrate state is most commonly due to involvement of the base of the pons in its rostral portion. That is, involving these motor tracts indicated here. So I will show damage extending throughout this region. Then going down to this last diagram, you recall that there was failure of horizontal movements to reflex activity, and that means that the gaze centers of the pons have been destroyed there. Finally, the phenomenon of ocular bobbing, which we saw, indicates that there was massive destruction of the pons, which confirms our other localizations. Now, if we can return to this top diagram, from the sagittal point of view, one can draw in the injury something like this. There is a very severe zone of destruction which is bilateral and having this distribution. It is compatible with occlusion of the basilar artery with infarction of the pons and midbrain.